Hello, it is now 2 p.m. Eastern Time. You have joined the Justice and Mental Health Collaboration Program Fieldwide webinar on using responsivity principles to attain better results for people with behavioral health needs in the justice system. To allow for additional sign-ins past the hour, we will be starting this webinar in a few minutes. Good afternoon. Thank you for joining today's Justice and Mental Health Collaboration Program Fieldwide webinar on using responsivity principles to attain better results for people with behavioral health needs in the justice system. My name is Ethan Kelly, and I am a Senior Policy Analyst at the Council of State Governments Justice Center. I will be moderating today's webinar, which is hosted by the U.S. Department of Justice, Bureau of Justice Assistance, or BJA, and the Council of State Governments Justice Center. Next slide, please. To give you an overview of today's webinar, first we will do introductions of our speakers and organizations. You'll hear a presentation on responsivity principles regarding screening, assessment, and treatment, risk reduction, and using a trauma-informed approach. Toward the end of the webinar, we'll have time for questions and answers. A few housekeeping items. Anytime during the webinar, you can ask a question by clicking on the Q&A button at the bottom of the screen and entering your question. This includes both technical and content-related questions. We will try to reply to technical questions in the chat as we go. For the content-related questions, we will keep a running list and address them at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please click on the link that we shared within the chat. Please understand that there are some technical issues that we may not be able to resolve. We are recording the webinar and we will post it along with the PowerPoint slides on our website within 1 to 2 weeks. And now for introductions, I'm going to hand it over to David Demora to introduce himself. David?
Hi, folks. Apologies. My screen just went crazy for a moment. My name is David Demora. I'm a senior advisor here at the Council of State Governments. I have been with the council for about 13 years or so, and prior to that, worked in the field for 35 years and have done a lot of work around the intersection of criminal justice and behavioral health. I'm a clinician by training, and most of my adult life has actually been at the intersection of behavioral health and criminal justice. So very nice to be able to chat with you all. Look forward to continuing as we move forward with this presentation this afternoon.
Great. Thank you, David, for being with us today. Next slide, please. So the BJ's mission statement. So BJ works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement and promote a safe and fair criminal justice system. Next slide, please. Justice and Mental Health Collaboration Program, which many of you are familiar with, helps states and local governments and tribal organizations improve responses to and outcomes for people with mental health conditions or co-occurring mental health conditions and substance use disorders who come into contact with the criminal justice system, and support public safety by facilitating collaboration among the criminal justice, juvenile justice, and mental health and substance use disorder treatment systems. Next slide, please. A little bit about the Council of State Governments. The CSG Justice Center is a national nonprofit, nonpartisan organization. We combine the power of a membership association representing state officials in all three branches of government, and our staff really strive to develop research-driven strategies to increase public safety and strengthen communities. Next slide. Just a little bit about how we work, bringing people together, driving the criminal justice field forward with original research, building momentum towards policy change, and certainly helping to provide expert assistance in this area. Next slide, please. And just quickly about our goals. So reducing crime and incarceration among youth and adults in contact with the justice system, bringing people from diverse systems and perspectives together to improve policy and practice related to these challenges of health, opportunity, and equity. And our work transforms information into meaningful insights through data collection for policymakers. Next slide. The Council of State Governments Justice Center is committed to advancing racial equity internally and through our work with states, local communities, and tribal nations with a focus on the criminal and juvenile justice systems. Next slide. And now I'm going to hand it back over to David to start our presentation for today. David.
Thanks, Ethan. And again, hello, everybody. Look forward to chatting with you over the next hour or so. And as you can see here in terms of the outline, we're going to start with a brief review of the risk-needs-responsivity model and risk reduction. For those who may have been on the previous webinar, my apologies, but we do need to do a brief review, particularly if we have some folks who may have joined this webinar and weren't on the last one. And then we'll talk about the issue of responsivity and tailoring treatment to the individual. We'll talk some about understanding, we'll talk some about understanding trauma and responsivity and the principles of trauma-informed screening, assessment, and treatment, and what that is not as well. And then we'll have some time for questions and answers toward the end. So let's get started. Next slide, please. First of all, risk reduction, sort of a brief review of that. What is it really all about when we talk about the risk part of risk needs and responsivity? Well, what it really helps us do is the risk principle helps us to understand who it is that we should be focusing interventions on. It helps us develop accurate assumptions about which individuals are more likely to commit a crime than those who are less likely. And it helps us to effectively target interventions and supervision to lower the likelihood that a person will commit a new crime or that they will fail supervision. And it is important to understand that the idea of the risk principle and risk reduction isn't to grab everybody into working with us or us working with them. It's to genuinely say, look, there's a group of individuals who may have done the wrong thing and may have been held accountable for that. But in fact, there is nothing more that is needed. We do not need to expend other resources or programs, whether that's supervision or correctional intervention or treatment for them in order for them to do well. And that there are a group of individuals, those individuals who are more likely to have difficulty succeeding, who indeed we should be spending more time with, if you will, and providing more services to. To be clear, there is nothing about the risk principle that says that if someone is not at high risk to recidivate, but still has significant other needs, that we should ignore those other needs. For example, if they have mental health or substance use needs that may not be related to the criminal behavior in any way, or other kinds of needs like housing. There's no suggestion that we should be ignoring those, but there is serious suggestion and important to understand that we might help them get those needs met, but we shouldn't keep them trapped in the criminal justice system as a way to get those needs met. When we do that, we essentially increase the potential for their failure. Next slide, please. Risk reduction means using the risk-need-responsivity model, or R&R. The risk principle, again, is matching the level of service to their likelihood to reoffend. Higher risk means more intervention, more structure, more supervision, and more of your resources. Next slide, please. To have enough resources for those higher risk individuals, we need to allocate fewer resources to folks who are at lower risk. So again, lower risk, less criminal justice intervention or correctional intervention, less structure, less supervision. Let us not waste officers' time, if you will, on individuals who will not benefit from that kind of supervision, and less use of resources. Once again, I need to make the point that this is not to say that if individuals that we see have significant needs, other needs, that may not be criminogenic in nature, directly crime related, it doesn't mean that we shouldn't refer them for services, help them access those services, etc. It's that that's not what we within the criminal justice structure should be providing to them. We should let the, if you will, regular or typical community resources provide those services. It is incumbent on us to help them to access those services. Next slide, please. Okay, so we know who. Next, please. So what do we do? Next, please. We look at the issue of criminogenic needs and the need principle. Criminogenic means dynamic or changeable factors that contribute to the likelihood that someone will commit a crime or that someone will fail on supervision even if they don't commit a new crime. In other words, they commit a violation that they may not have been in trouble for if they weren't on supervision, but it was still the wrong thing to do, and it still potentially created some difficulty. Certainly for them, it creates a difficulty in that that supervision failure may cause them to either have their supervision extended, or it may cause them to be incarcerated, or to have a period of incarceration that had been basically taken away, if you will, that they were able to do that under community supervision, now given back to them, and they are back in the prison or jail. And even if it's for a short period of time, it may be so problematic in the sense of them losing their housing or losing their employment, etc. So that it is equally important that we think about what we can do to keep people from failing on supervision as it is to keep thinking about what can we do to keep them from committing a new crime. The need principle says, let's assess what those needs are, and let's target those needs with the appropriate types of treatment and intervention. And that treatment and intervention may be, quote, correctional, meaning it may be specifically targeted at the criminogenic needs. But as we'll talk about a little bit later, sometimes it needs to be targeted at other things in order to be able to successfully respond to the criminogenic needs. Next slide, please. So again, a quick review in terms of some major risk and need factors here. First, what you see here is family and marital, for example, and what you typically see there are weak elements in terms of nurturance and caring and poor monitoring or supervision. The need there is to reduce conflict and build positive relationships and enhance monitoring and supervision meaning of children, to be clear. In terms of substance use, you see misuse of alcohol and other drugs, and we're looking to reduce substance use there, reduce personal and interpersonal supports for substance-oriented behavior, and enhance alternatives to drug misuse. And I want to make a point here. It is, of course, typical that when people are under supervision, they are disallowed from using any substance, whether it's legal or not. And there are a variety of different opinions as to whether that makes sense for everybody on supervision or not. We're not going to get into that discussion, but what I do want to make clear here is that there may be people who have a misuse of alcohol and drugs who don't necessarily ultimately need to be abstinent to do well. And so the issue is, are they misusing them? Are they overusing them? What are the issues that are involved? And is it an issue of there needs to be a reduction in their use, or is it an issue of they really need to stay away from these things over the very long run, because every time they get re-involved, something falls apart, if you will, something fails. And so separate from the issue of there may be a supervision rule, we should really be thinking and assessing about what it is that they need over the long term. And I mention this because very often people who don't need substance use intervention are ordered to substance use intervention. And that is a waste of resources. And we need to really distinguish between whether or not it's an issue of they need to behave better in their consumption, or they have a significant issue / addiction / substance use disorder in terms of what it is that needs to be dealt with and responded to and treated over time. In terms of antisocial friends and peers, the characteristics, of course, is basically hanging out with other folks who are also folks with criminal thinking. Not surprisingly, then often a lot of isolation from anti-criminal others, often because they've been rejected by those folks, and then immediate social supports from their friends for criminal behavior. And so the needs there are really reducing that association and the development of having them have relationships with folks who are, quote, anti-criminal, or as we more typically say, pro-social individuals whose solution to problems in life isn't first some thought that has to do with criminal behavior, but it's something that has to do with a socially acceptable problem-solving process. Next slide, please. When we talk about the major risk-need criminogenic factors and the dynamic needs, there's a number of different components here again, and you can see here in this list, antisocial attitudes, antisocial friends and peers, personality pattern, all of those having to do with that sort of antisocial component of stuff. And then again, you see the family and marital, the substance abuse or substance use. In the model itself, they use the phrase substance abuse. Obviously, we know that these days we tend to talk about substance use disorder, substance misuse, et cetera. But if we're looking at the specific model, the way that they have it written is still utilizing the phrase substance abuse. And then issues in terms of school and work, and issues in terms of leisure and recreation, which have to do back again with that issue of fundamentally hanging around with folks who are antisocial or are supporting criminal behavior versus pro-social. And in terms of responding to these things, there are a number of things that are necessary. And the first one has to do with communication skills. And whether that's judges, supervision officers, service providers, mentors, the jail or prison staff, communication skills are a key issue in terms of being able to connect with and work with folks in terms of what their particular needs are. There's a difference between telling somebody what their needs are and reaching a decision with the individual about what their needs are. And in the risk-need-responsivity model, the concept is not you tell them what their needs are. The concept is that you assess and determine objectively, if you will, what those needs are that exist, and that you then basically go on the journey with the client, with the individual, the supervisee, whatever language you may use, to be able to reach an agreement about what those needs are in order to be able to effectively respond to them. And you're reaching that agreement, not just in terms of what the actual needs might be, but you also need to reach an agreement about what the order is in terms of being responded to. Now, there are times, if there's a direct, immediate community safety issue, that we have to make that decision. But many times, there is not an immediate, direct community safety issue, and there isn't a reason for us to say to the client, you will follow the order that I say of meeting these. We can work with them to say, what makes the most sense to work on first? What are we going to work on second, or what combination of items? And then the service responses include things like addiction treatment, co-occurring disorder treatment, job training and employment, employment readiness, and of course, supervision. But supervision is really supposed to be a skill building process as opposed to a catch them process. So when we talk about really good supervision, we're talking about supervision that is providing skill building alternatives and options for the individual that is being supervised, and that works in conjunction with these other treatment or training services that you see on the bottom part of this slide in terms of addiction treatment, et cetera. Next slide, please. Okay, so that was the brief review in terms of risk needs responsivity. Fundamentally, there's the issue of risk and needs. Risk tells us the level of intervention that is required. Needs tell us what the particular areas are that we need to focus on. And as you saw in some of the previous slides, it also talks about some of the ways to do that, some of the ways to respond, and to what services to provide. Where we have often fallen down, even when we have had those first two components correct, has been in the issue of responsivity and not tailoring treatment to the individual the way that we really need to do so. So let's talk a little bit about that now. And if we could go to the next slide again, please. So again, the risk principle tells us who, the need principle tells us what, the responsivity principle tells us how. So who, what, and how. Next, please. When we talk about how we respond, overwhelmingly cognitive behavioral interventions tend to be the most appropriate set of responses. And there's a wide range of cognitive behavioral interventions. There's manualized programming, things like thinking for a change, freezing and rehabilitation, MRT, and a variety of other things. And that's just 3 of easily 25 or 30 that exist with slightly different foci depending on which particular program that you're looking at. There are programs looking at specifically at alcohol and substance use issues, programs looking specifically at DUI and drunk driving issues, programs looking specifically at sexual violence or domestic violence issues. So there are lots of different types, as well as some general cognitive behavioral intervention programs. And then in addition, there's cognitive behavioral therapy, which is a level above cognitive behavioral interventions. Now, in all of these cases, when we talk about, quote, CBT, and we tend to talk about CBT in the criminal justice field very loosely. We always talk about CBT. The truth is that a lot of the work that we do with correctional interventions are CBI, meaning that they're programs that don't necessarily require a licensed individual to provide. Once we get into CBT as in therapy itself, now we're talking about the need for licensed individuals to provide that. But whether we are talking about interventions or therapy, this cycle tends to be very similar in terms of what it is that is being looked at and what it is that we're attempting to intervene with, if you will, or to interrupt. Starts out with the issue of the situation, which basically, what are the conditions that led to the behavior, right? What are the people, places, things? And then it leads from there to the thoughts. What are the thoughts that people have which drive the behaviors, which leads to the feelings? And this is an important piece in that some folks like to go right to the feelings and ignore the thoughts. But the reality is you don't have a feeling without having a thought first. If I used to say, look, if I remove your brain, you're not going to feel anything, right? In order to have a feeling about something, happy, sad, anxious, whatever, you have to have a thought that drives that behavior. Also, some feelings are secondary. Anger tends to be a secondary emotion, for example. But whatever those feelings are, they come from a thought. And that thought comes from a situation, whether that situation, again, is something that has happened to us, someone that has said or done something to us, or a place that we are, just to use the most obvious ones. Now, feelings can be healthy or they can be problematic, and that depends obviously on how one copes with those feelings. Even feelings of, for example, sadness can be very healthy and appropriate, or they can be very destructive. It's not the feeling itself that has it's not the feeling alone that has the impact. It's the connection of the feeling and the thought that goes with it, and what it is that what kind of skills we have in terms of coping with particular feelings. To put that another way, if the way that I cope with being sad is that I have a discussion with my significant other about being sad, that is potentially a very healthy kind of response. If my way of dealing with being sad is that I drink a whole bottle of bourbon, that is not a healthy response. That is a problem. So it's the feeling and our response to it. And so that becomes the behavior, right? The ultimate behavior that we engage in, which can be positive or can be negative. And if it is negative, then the consequences will be negative. And so the general cognitive behavioral cycle, or CBT cycle, holds true whether we're talking about criminal behavior or general mental health issues or general just day-to-day behavior in how we live our lives. That cycle is consistent. What changes are the things within it. Or to put it another way, to go back to the sad feeling, my sad feeling might bring me to talking with my significant other. Someone else's sad feeling might be coped with by them getting angry, and then them getting angry makes them look for a fight, and then that fight is the behavior, and then they get arrested for that fight because of whatever, disorderly conduct, assault, battery, whatever, and now the consequences kick in, and we are in this problem with the cycle. And so whether we're talking about criminal behavior or we're talking about just general behavior, this cycle is relevant in both instances. Next slide, please. So when we talk about responsivity, we're talking about tailoring treatment to specific individuals and styles. The first one is being responsive to learning styles. And in general, as you saw in the previous slide, cognitive behavioral interventions tend to be the most successful in many, many instances, not just in again, criminal behavior or lowering criminal behavior, but also in many other areas for mental health, whether we are talking about substance use issues, anxiety, depression, etc. That is not to say that CBT works for everybody all the time, or that it is the only thing sometimes to do, or that there is only one form of CBI or CBT to do. There are different types in both cases. And so it's not an issue of there's only one thing to do. There is an issue of when we look at the different forms of therapy, we find that overall, CBIs and CBTs tend to be among the highest success rates. But they're not the only things, and they're when people get into these arguments about if it's not CBT, then we shouldn't be doing it. And the answer to that is it depends on what you're trying to do, and it depends on what the issue is. When we're talking about lessening criminal behavior or meeting criminogenic needs or resolving substance use issues, the studies consistently show that we get the best outcomes when we use CBIs and CBT. And again, there's different types, right? DBT is one type. Thinking for a change is an intervention, not a therapy. That's another kind. So there's different types, but they all have something very similar in common in that they are, quote, cognitive behavioral. They combine those two areas. And then the second piece is the specific, which is responding to sociobiological personality factors, how we engage with folks, how people respond to different things, the difference between if you're treating me as an older white male versus treating me as a 21-year-old white male versus treating me as a 25-year-old person of color versus treating me as a female versus treating me as straight versus gay, again, on and on and on. Lots of different specific factors that are important to know in order to tailor treatment. One of the criticisms sometimes of the manualized programs is that they don't allow for that. It is actually a false criticism. It's not that those programs don't allow for it. It's that often we don't train the people providing them to be able to do that. And so I can use the same curriculum, but I can approach it differently depending on the particular factors and needs of the individual that I'm speaking with or that I'm working with. And so we need to disaggregate poorly trained facilitators from whether or not manualized training is always bad. Having said that, sometimes manualized training is not enough, and there need to be additional, if you will, one-on-one or tailored personalized interventions. Next slide, please. And so here's another way to think about it in terms of what I was just saying. These are key principal factors in terms of responsivity. And they're all important, but we start out with client factors, bottom line. I was having a discussion earlier today with some colleagues, and interestingly, it wasn't about clients, it was about working with colleagues and working with legislators and working with states and folks that we work with. And I was saying that I treat each engagement that I have with all those different folks in a lot of ways that I treat thinking about client engagement. That the first thing that I look at and think about are what are the particular client factors, right? And so those factors are going to be very different depending on where I am in the country, whether or not I'm working in a red state or a blue state, whether or not I'm talking to folks who are more conservative or more liberal, whether or not I'm talking to older folks or younger folks, and on and on and on. And so in some ways, it's no different than thinking about how do we intervene in the best way with the clients that we work with. So the first issue is understanding or assessing client factors. The second issue is relationship. Even if you have the perfect manualized program, and there is no such thing as a perfect anything, but you have a very good manualized program that has been validated and shown to have good outcomes, or you are doing CBT, or your agency is using the most progressive techniques in what they're doing, et cetera. If there's not the relationship that gets developed with the person you are working with, doesn't matter whether you're a therapist, it doesn't matter whether you're a supervisor, it doesn't matter whether you're a mentor, whomever you are, if that relationship does not get developed, then there will be limited impact of even a very good curriculum or good treatment process / program. Alternatively, when there is an excellent relationship developed, it actually helps make up for what are sometimes weaknesses in a particular program or particular approach to whatever the problem is. So it becomes extremely important. So first issue, biggest amount of a pyramid here, if you will, client factors. Who is the person? Understanding who they are. Second is developing that relationship. And I'm going to add a third thing to that in terms of relationship, which is in my life, there have been times that what I have figured out after understanding the client factors and understanding who I am, that because of either my own limitations, my own biases, my own whatever, that I was failing at developing that relationship the way it needed to be developed. And so what it meant was that I needed to say, the problem is not that the client is being resistant. The problem is I'm probably not the right person for this client. And whether I'm, again, doing that clinically, or I'm doing that as a supervisor, a probation or parole supervisor, the same rules apply. And it is important to understand that if we can't develop that, first of all, we have to look at ourselves. And to be clear, I'm not saying that in a self-blaming way, and I'm not blaming supervisors or clinicians. There is no one in the world that can develop a relationship with anybody else or everybody else in the world. We all have our strengths and our weaknesses. So it is important, if that relationship is not developed, that you think about who else should be working with this individual, because no matter, to get to the next one, no matter what technique you're using, you're not going to get to where you need to go. So you could be using a great technique, but not have assessed the client factors, you have a problem. You could be using a great technique, but you have a crappy relationship with a client, you have a problem. You could have a really great relationship, and even if you're not so good in your techniques, and it's interesting, a number of years ago, they did a couple of studies around this, and what they found was that when the spirit of the work was being moved forward adequately by the individual doing the work, the clinician, the supervisor, excuse me, even if they weren't doing it perfectly, the outcomes were very good because the relationship helped make up for that issue. And then the fourth piece here at the top has to do with expectancy. And expectancy includes the supervisor characteristics or the therapist characteristics. In other words, if I approach, as I go around the country, I see these things sometimes. I've talked with, probation or parole officers who, believe that pretty much all their clients are destined to fail, and their job is to catch them before they do. I've talked to therapists who say, sure, I work with problem people or people who have problems, but not criminal justice people because they're different. So their expectancy in terms of people being able to move forward to be successful is low. And so if you don't have a high expectancy of success, then even if you've done fairly well with the bottom three here, you're not going to get the outcomes. I will tell you that people who do fairly well with these bottom three tend to do very well at the top. Okay. And that's the reason for the order in the pyramid, if you will, right? That as each one goes from bottom to top, from client factors to relationships to techniques to expectancy, what you find is that as the bottom part of the pyramid gets done well, and then the middle part, by the time you get to the top, excuse me, again, it tends to work very well. And so rather than start at the top and work down, we're starting at the bottom and we're working up. The next slide, please. My apologies for my constant coughing here. I'm having one of those allergy days. And so in terms of responsivity, again, we're talking about maximizing the person's ability to learn. It's all about what helps the person learn. We need to stop thinking about whether the client is resistant. And again, I use the word client, by the way, whether I'm talking about the client of a clinician or a probationer or parolee, where depending on where you are in the country, they also call them clients. And then other folks don't call them that. They call them probationers or parolees. I am using the word client regardless of whether we are talking about the supervising agent or the person providing clinical intervention. So I want to be clear about that. In both cases, the issue is not about assessing the resistance of the individual per se, or blaming the lack of ability to reach that person on the resistance. It's about figuring out what we can do to broach that resistance. And there's sort of two things, by the way. First of all, we have to determine whether there really is resistance. A good number of the time, or many times, we define what are either cultural differences or cognitive differences or processing differences as resistance, when there's simply things we've not recognized that are different from how we behave, think, act, etc. And then there are times when, yeah, a client is genuinely resistant. I mean, they don't want to change. They don't want to be held accountable. That's true. But then it's still incumbent on us to figure out how we're going to be able to help them move to that next stage, if you will. Think of it this way. When we're talking about criminal justice, if they didn't need our help in helping them accept the fact that they need to change, then they probably would not be in the criminal justice system. In other words, it's unfair to put it all on their shoulders. It's unfair to say to them, you should be thinking the same way I think because that's just how it is. Well, that's not true. They didn't get here because they woke up this morning and had a bad day. They got here because of a whole series of things, some of which we're going to talk about as we move forward here, that led them to this point. They may not have the skill set or the ability to recognize what those things are. Part of our job is to help them recognize that, not to tell them what it is, but to help them understand and recognize that as we move forward in our work with them. Next slide again, please. Responsivity means that it's not enough to target higher risk folks with the right interventions. You have to do it in a way that supports them as they learn the new skills that we're trying to teach them. It means being respectful. And it's important, this is an important statement, because when people reject the risk-need-responsivity model, and who I see to be very blunt and very honest, as someone who has lived at that intersection of behavioral health and criminal justice, I'm seeing a lot of folks in the behavioral health system sort of rejecting this model, and they say, no, it's all public health. It's not all public health. It is an integration of criminogenic and public health principles. There are issues that are related to people that are in the criminal justice system that clearly have a strong public health component, but there are also issues that are fundamentally criminogenic. And we need to not make the mistake that we made years ago, which is that we threw out all the genuine public health issues and said, only focus on these criminogenic pieces. That was a mistake. We need to make sure we don't go to the other extreme now, which is we go, oh no, forget that. We're just going to do this over here. There is no research to support that. The current research is suggesting that the integration of the two is the way to go. And there is nothing in the R&R model that says that we should be disrespectful of individuals, or that we should not be supportive of them, or that we should be telling them what they need. That has more to do with perversions of the model, not what the model was intended to do. Next slide, please. It also means focusing on people's personal strengths, strengths-based approach, and how specific individual factors might influence the effectiveness of treatment services. And again, when I say treatment services, I'm going to argue the same is true for supervision services as well. Next slide again, please. Okay, so how do we support people as they're learning new skills? Well, once again, we want to think about the issues, sorry, let me start that again. We want to once again think about the person's personal strengths and their personal characteristics when interacting with them and designing their interventions. Fidelity to a curriculum, and I started to say this earlier, doesn't mean that you have to behave exactly the same way with each person, despite their learning style and other needs. I'll often tell the story that back when I was doing ongoing treatment, I did group very often, and I did it with a co-leader. And my co-leader and I were, similar in some ways and very different in other ways. And Bill used to love to say that the two of us made a hell of a therapist. And what he was saying was that we both had different strengths and we both had different weaknesses, and that by acknowledging that, we were able to reach people in the group more effectively by not demanding that somehow they had to be able to respond to who I was, or that I had to be able to respond effectively to everybody. I needed to understand, no, I don't want to do that. And now it's time for Bill to kick in, or vice versa. Bill would be with someone and I would kick in because I could be more effective with that individual for whatever those reasons, just having to do with how it is that relationship developed, what those person's particular characteristics were, etc. Next slide, please. So are non-criminogenic risk factors important to include in an R&R assessment? Spoiler alert, yes. Next slide, please. In fact, they might have to be addressed before you can address the criminogenic needs, or they might have to be addressed at the same time, because in fact, they might represent a barrier to effective participation in treatment. And that's a problem. This was one of the mistakes that we made early on. When I say early on, I'm talking about late 80s, early 90s through the beginning of the 2000s, where if it wasn't directly a criminogenic issue, we downplayed the importance. And that's because we weren't paying attention to responsivity, only to the risk-need part of the model. We've learned over the last decade that was a mistake. Next slide, please. So what are some of those non-criminogenic needs that might need to be targeted to lower criminogenic needs? Self-esteem, anxiety, lack of parenting skills, medical needs, victimization issues, learning disabilities, mental illnesses, level of motivation, receptive and expressive language skills. And that becomes particularly important when there are language issues, as well as the issue of ability to read somebody might be able to speak English, but may not be able to read English or it can read English but can't actually conceptualize what it means the same way as if it was in whatever their particular native language was. Learning style, concrete thinking, and trauma. Trauma being obviously a major issue, and obviously some of these things can be connected together. One of the things that I started to say earlier when we were talking about the public health model, which is again important to integrate into this, is that we need to be very careful not to drop the criminogenic piece. If someone has a variety of criminogenic needs, that those central 8 that we know about, we may not be able to get to some of them without dealing with the trauma issues, or without dealing with their victimization issues, or without dealing with their anxiety or self-esteem issues, just to pick 4. In fact, dealing with those may make us more able to be able to respond to those issues effectively. But stopping there will not get us where we need to go. And I'm seeing some situations where people sort of say, oh, as long as I deal with that, everything will be okay. You know, we learned the hard way back in the 70s and early 80s that doing that alone would not work. We need to be careful not to go back to that time. Next slide, please. So how do you build on strengths and reduce the barriers to treatment? Well, the first one is how ready is the person to change, right? You want to meet the person wherever they are in their change process and not yell at them for where they should be, if you will. A lot of programs often want to take folks only after they're already ready to change. Well, that's a little late in the process. Most of the people that we work with who have significant needs are not quite yet ready to change. Then, is their mental health creating a barrier? Well, we need to treat the mental illnesses, free up their attention to participate fully in risk reduction interventions if they are higher risk and need. Again, if they are lower risk and need, they might just need some mental health intervention, and that's it. And we end right there. And that's all that we do. Next slide, please. So, relatively few places still identify individual strengths or protective factors that can be built on in treatment planning. Computer skills, for example, strong family relationships, a high educational level. And by the way, all that means is through high school. We're not talking about, graduate school or all those kinds of things. A history of stable employment, strong ties to a recovering community. We tend to assess too often the deficits, and we don't assess the strengths as well. It's important to do so as ways to think about reaching individuals. Next slide, please. Still too few programs effectively identify individual factors that might influence the effectiveness of the services. And here again are just some of those: anxiety, attention deficit disorder, motivation levels, obviously differences in how different genders respond to issues, reading levels or English as a second language, language in general. Next slide, please. So when we really think about sort of the model of treatment and related concepts to correctional treatment, we need to think about a number of different components. We need to think about the external factors, legal pressure, for example, that might be there, social network that they're involved with. We need to think about the treatment factors. What are the motivational interventions and style? What's the person's adaptation to learning style? Adaptation to learning style. What is their cognitive capacity? We need to think about their personality, age, if there's psychopathology, in other words, patient factors, right? And we need to think about some of the internal kinds of things. What's the perceived legal pressure, which may or may not be the same as external? What's their ability to recognize that there's a problem? What's the degree of distress that they are experiencing? What do they see as the perceived costs of treatment? And that might be a fiscal cost, or that might just be cost to them, psychologically, emotionally, in terms of familial or other relationships, etc. There's their perceived suitability of the treatment, as well as their outcome expectancy, and the overall motivation, of course, to engage in treatment leads to whether or not there is significant treatment engagement. So internal determinants, and you see that move to motivation, So you've got the external, you've got the internal. External feeds into the internal. External and internal don't always match up exactly. Then that goes to the person's motivation to engage, goes to their treatment engagement. And then you come back to the issue of treatment efficacy, whether or not you're effectively being able to respond to and treat the criminogenic needs or not. And not surprisingly, I hope this easily makes sense. If we work hard to get them if we figure out the internal determinants, we help them deal with whatever the blocks are in terms of those internal determinants, so that we can increase their motivation to engage in treatment and increase their treatment engagement, then we will have a much better overall outcome in terms of treatment outcome, and we will have a lower level of reoffending. So it's not just, I told you to take this program and do this. It's a lot of different assessment components. And these internal determinants are not something that we can simply boil down to, oh, they're resistant. These are genuine processes about how they're interpreting what may be some of these external factors that you see on the very left of the screen. And they may not interpret them. In fact, I can almost promise you, they do not interpret them the same way that we might if we were dealing with some of these same issues, given, assumingly, I'm assuming this for all of us on this webinar, the different past experiences and different sort of life events that we have had, as opposed to those that they have experienced in their lives. Next slide again, please. So engagement is one of those responsivity factors, and it's a key to change. Treatment outcome and premature termination is consistently predicted by the degree of engagement. Treatment outcome is related to patient effort. The therapist approach is related to engagement and effort. So let me say that again. Treatment outcome is certainly related to patient effort. If the patient doesn't do the work, then the outcome is not going to be where we want it to be. But our approach, the therapist/supervisor's approach, related to engagement and enhancing and supporting effort, is related to them being able to get through treatment. Or to put it another way, a patient's success, I won't say what state I was in, but I was in a state where I was talking to both the supervisors and the treatment providers, and they kept saying that ultimately the client succeeds when they decide that they're going to succeed. And my question for them was, well, where is your responsibility in helping them get to that decision? And interestingly, both the clinical and supervisory staff in this particular state, or at least this particular area of the state I was in, felt that it was not their responsibility, that it was all on the client's shoulders, and it all had to do with client accountability. And they were confusing, as I often say, they were confusing accountability with motivation, and they were confusing accountability with engagement. They're two different issues, and certainly clients need to be accountable if we're talking about clients who are in the criminal justice system. But that is a separate discussion. When we're talking about treatment outcomes and succeeding in treatment, helping that client be engaged, supporting their effort, is the responsibility of the clinical folk and of the supervisory folk. It is not all on our shoulders, but we share that responsibility with the client to have them succeed and move forward. Next slide, please. So let's talk about the clinical impact of incarceration, because so many of the people that we see, we may be seeing them while they're incarcerated, or we might be seeing them after release from incarceration. And by the way, sometimes that means sentenced incarceration, but sometimes it's pre-trial, right, where they're in jail for a month or 2 months or even a week prior to getting out. And we have, again, multiple studies that show that even short stays in incarceration increase the long-term failure of individuals. And so it may be that for community safety, there are times when that is necessary. We know lots of times at a pretrial level, it's absolutely not necessary to do that. But regardless, what we do know is that when it happens, that it increases the potential for failure. And when we look at the issue of the clinical impact of incarceration, a number of different lenses we need to think about. One, again, is the risk-needs-responsivity, because needs get increased when somebody's been incarcerated. We need to think about the issue of trauma-informed treatment, because incarceration, regardless of prior trauma, is itself a cause of trauma. And when we talk about cultural competence, it's not just the issue of cultural competence in the sense of working with folks from different cultures. It's cultural competence in terms of understanding what the impact of incarceration is on an individual and how that impacts and changes how they think, how they survive, how they look at the world, and how they look at us. Next slide, please. So there are a number of engagement challenges when we look at those issues in terms of incarceration. Some of the ways that we approach those things. The first one is, again, the issue of increasing motivation, or utilizing motivational interviewing at the initial stages to get them engaged, to engage the client in the goal setting and not set the goals for them, and a focus on recovery. Focus on recovery is different than a focus on recidivism reduction. Let me restate that. The sense for the client when you're focusing on recovery is different than the sense for the client than when you are focusing on recidivism reduction. In the end, if that focus on recovery is successful, you have actually developed recidivism reduction. So you're getting to the same end result, but you're doing it in a healthier manner. And then again, the criminal justice adaptation here in terms of culture is understanding the trauma that that individual has experienced as a result of, one, being involved in the system, period, and then two, more specifically, if they have been incarcerated, the significant traumatic impact that that creates for individuals. Next slide, please. So, risk reduction and responsivity. Hopefully many, if not all of you, are familiar with these concepts in terms of motivational engagement. We can express empathy with individuals. It doesn't mean that it's not the same as approving of their behavior or being sympathetic with them, that they are within the criminal justice system for having done something that they shouldn't have done. The obvious skill of rolling with resistance in terms of, no, I'm not right. You're wrong, I'm right. Basically giving up being right. What I find is that clinicians tend to be better at this in general than supervisors. There are exceptions on both sides, of course. Developing discrepancy, really looking at the client's own ambiguity and sort of back and forth about thinking about their issues, their teeter-tottering, if you will, and really beginning to look at that and develop the discrepancy in their thought process when they are perhaps being resistant, if you will, about what the issues are or why they need to change. And then promoting change and helping them to believe that they have the power to change, which means we have to believe that they have the power to change. Next slide, please. So when we talk about cultural competence in this scenario, again, to be specific, we talk about cultural proficiency in this scenario, to be specific. We're talking about the meanings of the symptoms of the illness, of the stressors, to understand what those are, rather than just put those as the client being pain or the client being resistant. Understanding the meaning of treatment and how people see treatment. Understanding how they see the relationship with professionals as a result of the trauma that they've experienced, which fundamentally means that they mistrust professionals, that our communication with them needs to be developed and designed in a way that matches how they speak and think, not how we speak and think, that the development of rapport means doing so on their in their ballpark, if you will, giving them the ability to decide how quickly and what method. and that their disclosure about whatever it is that those things are that need to be changed or that are issues needs to also be done in their own time as opposed to forced. Now, there are, of course, some limits to this, right? We can't do this over 20 years kind of thing. There has to be some balance. There's some lengths of time where we have to sort of push, if you will, and to push that the person to be able to move and to change. But what we often see is that people try to do this upfront very quickly, as opposed to really giving people room to breathe and to grow and to develop for a period of time, usually a much shorter period of time than you think, in order to have them open up and do the things that they need. Or to put it another way, when we tell them that they have the authority and the power to figure that out and to make those changes, they tend to run with it much more quickly than when we tell them what they need to do. And then using natural community supports. So what are natural community supports? Well, there are lots of different things. Obviously, it might be, quote, in the community, people in the community, might be family, but it also means mentors. It means other folks with lived experience who have already gone through all of this and who can work with those individuals. I am more and more convinced that one of the biggest failures still today in the work that we do is our lack of developing and assuring the existence of peer mentors for a large majority of the individuals who are coming through the criminal justice system. They do not all need a mentor, but a very large number of them really would benefit tremendously from having someone who with lived experience who has been able to succeed, be successful after the trauma of their involvement in the criminal justice system or incarceration, if you will. Next slide, please. Incarceration is a cultural adaptation. Those of us who do assessment research in correctional settings must continually remember that we are dealing with atypical, highly biased samples of people who've been exposed to massive situational influences specifically designed to alter their attitudes, their personality, and their behavior. Incarceration in and of itself is a massive intervention that affects every aspect of a person's life for extended periods of time, meaning for many years after that incarceration ends. Next slide, please. And from the Shawshank Redemption, sort of the simple way of speaking about what I just said, these walls are kind of funny. First you hate them, then you get used to them. Enough time passes, get so you depend on them. That's institutionalized. Next slide, please. What are the cultural norms for people that are in jail or in prison? Well, do your own time, mind your own business, trust no one, show respect, even if you don't have it, ignore others' infractions, don't steal, don't snitch, don't show weakness, don't stare. When you look at trust no one, don't snitch, don't show weakness, those are things that very much get in the way when we start asking them to do the work with us. Next slide, please. So, principles of trauma-informed screening, assessment, and treatment. Next slide. Trauma results from an event, series of events, or a set of circumstances that are experienced by an individual, is physically or emotionally harmful or threatening, and that have lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Van der Kolk, one of the grandfathers, if you will, of looking at trauma research, defined trauma as an event that overwhelms the central nervous system, altering how we process and recall memories. Next slide, please. So when we're using a trauma-informed perspective, we're thinking about some of the consequences of trauma, the isolation that the individual experiences, their hypervigilance about everything, and their emotional reactivity to whatever it is that's going on around them. And so in those situations, we need to think about the issues of, are we providing a safe environment? And safe might be physically safe, or safe as in making sure that there's no physical harm. But what we're also talking about is safe in the sense of course, emotionally safe in terms of we providing a safe environment. Secondly is processing that trauma, meaning processing the trauma with the individual, and then helping them identify a variety of coping strategies in order to deal with and resolve whatever the particular trauma is that they are experiencing. Next slide, please. So trauma can be both a responsivity factor and a criminogenic factor. The role of trauma in the assessment and treatment of justice-involved individuals is significantly expanded in recent years through an explosion of the research on the interaction of trauma, particularly complex trauma, with criminal behavior. Or to put it another way, when we look at people in the criminal justice system, we find that many of them have experienced complex trauma in their histories, whether that's as children or as young adults, but that it has happened over a long period of time, and that in fact, it ultimately becomes a criminogenic factor. And what we mean by that is that we can tie it directly to the fact that they are now involved in the criminal justice system. Next slide, please. The majority of the individuals in the criminal justice system have frequently been exposed to severe trauma, both as children and as adults. Trauma-informed assessments and treatment are critical in delivering services to these folks. Trauma-informed does not mean that we don't do certain assessments. It means, one, we want to assess for trauma, but it means that when we're doing other assessments, for example, of criminogenic risk and need factors, that we are doing so in a way that is trauma sensitive or trauma informed, that we are not doing them in a manner that increases the trauma for that individual. Next slide, please. Individuals who experience childhood neglect and abuse increase their risk of being arrested as a youth by 53%, and their risk of adult arrest by 38%, and the risk of committing a violent crime by 38%. Breyer, Attain, and Dietrich found that although 4% of the general population had sample, had symptoms of PTSD, 48% of their prison sample had symptoms of PTSD. And Whittam highlighted, however, that most of the abused and neglected sample did not commit crimes. Or in other words, retrospectively, we know that there's a large number, overwhelming number of people in the criminal justice system with these histories of significant PTSD and complex trauma. That is not to say that the majority of people with complex trauma or PTSD commit crimes. And it's really important that we do not confuse retrospective issues with prospective issues. It would certainly be unfair to go to individuals with those particular issues and say, oh my goodness, you're going to commit a crime. That's not the case. So remember, we're talking about understanding the sample of people that we have in the criminal justice system so that we can look at what some of the things that got them here and respond to those things. We do not want to then say, oh, if this happens for somebody, childhood issue, complex trauma, et cetera, that automatically means that they're going to, quote, be criminal. That is not true. Just like when we can look at folks with general mental illness, we can find that looking retrospectively, folks with general mental illness in the criminal justice system have a significant number of criminogenic needs, but it doesn't mean that the majority of folks with mental illness that might have some of those needs, housing, employment issues, funding, fiscal issues, et cetera, it doesn't mean the majority of those folks are going to end up in the criminal justice system and or become violent. Next slide, please. Okay, well, I actually did that in 5 minutes less than I normally do. We've got time. So we are at the last section here in terms of just any questions and answers. I don't know if any have come in, Ethan, for discussion, but happy to respond if there are any.
Thank you, David. I don't see any coming in through the questions yet, but I think now that you announce it, they will. Let's see.
See, we deal with soft handoffs, as in walk our clients through whatever process that may be. Good idea. That's an excellent idea.
So we have a question that came in.
Yep.
So typically, with which partner are you typically finding CBT interventions are being conducted? With supervision services, APO, at a CBHC, the treatment provider, with an intensive case management service? We have all of the above and struggling with a place to implement something when clients are coming in from an entire county, geographically diverse area. Is it better to implement an intervention in a group setting with more than one participant, with one of the partners mentioned above, or one-to-one with a counselor, supervisor, or case management?
So there's no one answer to the first part of the question, which is that part of it depends on where you are and what's available. So in some places, you're going to see the supervision services doing the CBT interventions because they have no community services available to them. It's only the only way to provide them is to have officers, agents, depending on what they're called, trained to do that. You will see it in CBHCs. You see it less in the traditional CMHCs than in the more in the broader, if you will, CBHCs that have been developed over the last several years. You certainly will often see it with intensive case management services. One of the problems I think that you often see is that looking at all of those different groups that were just mentioned, is that rather than them getting together and thinking about how to have an integrated approach, they develop all of them in a siloed way and sort of say, okay, I'm going to do it over here, or I'm going to do it over here. So if more than one of those things exists in a county, a state, again, depending on what we're talking about, it makes much more sense to find a way to pull those folks together and to think about how to have a much more integrated approach to that, especially since it is not atypical that more than one of those groups will be touching the individual. And if more than one of those groups is touching the individual, the better that each group can reinforce the other, the better off we are. And one example I can think of about that, this is not a community example, but for a number of years, I did work in the mental health unit in our maximum security facility where I live. And one of the things that we did over time that we were able to do at that time was we were able to train the COs in that unit in the same processes that we were using. And we were able to have those folks be in that particular unit. So the clients we were seeing in the mental health unit were in a particular unit in the facility, and they had COs who were working with them in the unit and with us on the mental health unit, so that we were reinforcing what it is that we were doing, both when they were with us in programming and when they were in their housing units. And then as far as is it better to implement an intervention in a group setting with more than one, or one-to-one with a counselor, supervisor, or case manager, there is no right answer there. Generally speaking, you see group being the majority process used, in part because of a cost-effective issue. What I see happening in a lot of places, and makes a lot of sense to me, is that they'll start individually. And they might do somewhere between 2 and 10 individual sessions to be able to develop some of the things that I was talking about earlier, in terms of the relationship and the trust, et cetera, and then move them into a group. Now, having said that, those would be for the people that I would define as the most fragile. Then there are the people who have the biggest issue with dealing with us because we're the professional. I want to start them in a group with some folks that have already been moving forward so that they can help them move forward in terms of their interactions and responses to us. In other words, to have people that have already developed the trust and the relationship with us and vice versa, help their peers develop that trust and relationship and understand what it is we're trying to do, and that what we're not trying to do is to harm them in what it is that we are providing or asking them to be a part of. I think I answered both parts of that.
Yes, thank you, David. Here's another one for you. So is there a substance abuse treatment curriculum you would recommend for the adult prison population?
So the University of Cincinnati has one that is being utilized in a number of places. That is a decent one. I don't think there's any great one out there. And so there's decent and there's great. I think that when we're talking about substance use education and when we're talking about substance use issues that are that also relate to the issue of other criminogenic needs, that curriculum such as the one at the University of Cincinnati is a very good one to use. I think once we're getting into folks who have high substance use needs, but not high other criminogenic needs, that really, it's not a curriculum, it really is substance use treatment, and whether that's MAT and or ongoing clinical intervention, that something like a quote curriculum by itself won't get us where we need to go with that individual. I'm sorry, I just blanked on the other one I was going to tell you. There's a good DUI curriculum that's driving with care as well, specifically looking at that issue of substance use that can be used in facilities or in the community. And there is a third one that very honestly, I am blanking on the name of it, but also has some good outcomes from the change companies. And I will look that up, and when Ethan sends out the recording or the link to the recording, I'll just ask him to include the name of that as well.
Thank you, David. Is there a time frame per client you should give? We lose a lot of clients that do not follow through even when showing up. So I think to me, the question about is there some flexibility in terms of compliance and things like that, or some stipulations that they may have to follow?
Sorry, Ethan, ask me that question again.
Sure. The question I believe is about reporting, and is there some time frame that they should give for clients? They lose a lot of clients due to not following through even when showing up. So around treatment and things like that. So around compliance, is there flexibility within some of those things that may be stipulated on folks?
So I think if I'm following correctly, what happens is that what they're saying is that the clinical people lose a lot of clients because they get violated for not coming to treatment. Did I get that right?
That's how I'm reading the question or understanding it.
Okay, so there should be some flexibility. I will say that the majority of states these days, and that doesn't mean it's the same everywhere in each state, by the way, to be clear, but that more and more what you do see in supervision agencies is trying to give people more leeway than in the quote old days. When I started, you missed one or two sessions, then you were going to have a technical violation. These days, what you see more and more are folks really sort of saying, wait a minute, we really need to think about motivational engagement. We need to think about, as the officer, helping the person get to treatment and to go to those different programs. Now, two different things to think about that. One, if whatever the particular substance use need is so severe that potentially they're going to harm themselves as a result of not showing up, you're going to need to respond more quickly. But that then begs the question as to whether or not the particular level of service that's being provided is the right level of care. And then the second issue is there are some folks whose criminal behavior is directly linked to when they were using the substance. And so you've got a higher community safety risk. And so you're going to need to be much tighter with that. Is there a rule of thumb about number of sessions to miss or not? There really is not one, answer. And what you see are that, frankly, clinicians themselves are all over the place. I was assessing one place where if the clinical people, if they missed one session, they threw them out. I was assessing another place that said, oh, no, you can't fail. Doesn't matter how many sessions they miss. we'll take them back if they do that. And not surprisingly, the supervising officer somewhere around the, eighth miss was going, I can't have this. I have to respond. I can't simply let the court order be ignored. And so I think one of the first and most important things is for the clinical person and the supervisory person to sit down together, or virtually or otherwise, and to say, let's talk about what our plan is going to be about this. And so let's talk about, so if Joe's being referred for this program, let's talk about, what are your concerns, officer, about this individual in the community? Here's what we've seen in terms of our assessment. How do we want to approach this if he or she misses a session, and what kind of leeway do we want to give them? And let's have a coordinated plan so that we're giving this individual the same message. And I see something here that says we receive court orders for clients to complete mental health centers at JDC. This often discourages clients from being forthcoming at the time of assessment. This is the case, they're using the detention facility as a means to get services. I am general. How do I want to say this? I'm generally against detention programs being used to provide the services that somebody needs, and I do understand that sometimes there may be no other options in a particular area, but and I'm working in a particular state now where, one of the places I'm working with says, oh yes, we don't have it, so we're just going to have to build it into the jail. And I would argue that what you're doing is just helping reinforce the lack of responsibility of developing the community services. And so I would certainly argue that that should not be the assessment. Again, we're assuming there's not a community safety issue here. I would argue that that assessment shouldn't be done in the detention facility, if I'm reading this question correctly. I would argue that it should be done in, for example, in one state I'm working in, one of the things they're doing and that we recommended was the development of some diversion facilities. And so they're not detention facilities. They are someplace that you go for 3 or 4 or 5 days where there's a bed for you, but it's not is the same as going to the jail and being behind the bars, if you will. Obviously, if that person were to leave that, then the judge is saying to them, here's your option. This is what you can do. Go here. If you don't do that and you leave, well, then this is going to be your other option. And now we are at the detention facility. But I think it's a much better way to do that. We also have done, or we also work closely with a judge in Florida, for many years now, who's developed some really nice alternatives to detention in terms of looking at how to get the necessary assessment for folks, and even treatment for folks in diversion centers, rather than them ending up in the jails and in the prisons. And this is in Dade County in Miami area in Florida. And it's a much better way to respond to those issues than to use detention. Where I live too, quite frankly, I saw this happening for a while where they were saying, we're going to violate them so we can put them in the prison treatment program. That's a bad plan. It's just generally a bad plan to do that. Remember what I was saying about the issue of the trauma, the cost benefit of that in terms of the harm versus the benefit. There's more harm than benefit. And so unless that person is a risk to hurt themselves or a risk to public safety, then you should really not be returning people to facilities specifically for the purpose of getting treatment. Is there a curriculum for COs on this topic? It's a great question. I would probably suggest that, let me think here. I would probably suggest some of the work by ACJI out of Colorado in terms of looking at this. Glenn Tapia is the Google Glenn Tapia ACJI, and it will get you to the name. I always forget the full name of what the acronym stands for, but they're doing a lot of good work around this issue and training the supervisors in the community, and also training folks who are working with folks with these issues who are inside. And so I would really suggest that you take a look at that. I would suggest that you take a look at some of the change company material in terms of that. And I would also suggest that you look at some of the work that NIC has been doing on this, along with some parole folks. And once again, I can't think of the exact name of the curriculum, but I'm making a note. And again, I will make sure Ethan has this info when he sends the information about the recording of this out. Let's see, curriculum COs. Let me just make that note, curriculum COs, as well as the other substance use curricula. Okay. And
David, there's just one more question about the names of the diversion facilities discussed. Were you referring to Judge Leifman, Miami-Dade?
That in that particular case, I was talking about Judge Leifman in Miami-Dade. They're also developing, they don't have names, but they're also developing those in New Hampshire at this very moment. And Rhode Island has developed an emergency center as well, where the police can bring people there in Rhode Island. And I can get you the full name of the Rhode Island. There is no formal name at this point in New Hampshire because it's a relatively early stage.
Excellent. You know, something I can just add about the diversion center in Miami-Dade, that the National Center of State Courts has coordinated and organized some visits for folks to go out and see the diversion center. So it is available. I see we are a couple minutes before time. I don't see any other questions coming in. So I do certainly want to thank all who attended the webinar today, and David for the presentation today. It was absolutely excellent. This was a part 2 of 2 sessions, so we do appreciate folks coming to both sessions. David, any final words?
Just thanks, everybody. Appreciate your listening. Hope that this was helpful, and I hope that people continue to think about the integration of R&R and behavioral health intervention. It is not one or the other that is the full answer. It really is an integration of the two if we're going to be effective with the very large number of individuals in the criminal justice system who have behavioral health needs. So thanks again.
Thank you, everybody. Bye.